तुहम कामने राज्ये ना सर्ग ना पुनः भव कामये दुखपस्तानम प्राणी नाम अटिन्नसनम. Natuham kamane rajye. I do not expect from any kingdom. Natuham kamane rajye, na sarga, heaven, na salvation. I want to alleviate the miseries of common people. Here tomorrow is. Your profession is basically for what? Natuham kamane rajye, na sarga, na pula bhavo. Kamaye dukha pastanam prani nama atinnasanam. Do devotion your time and energy for the benefit of the common man to alleviate the miseries without expecting anything. So today we are going to talk about the interlocking nail, particularly for tibia. It is true that today's scenario, it gives predictable result. What do you understand by that? Predictable result. Many results are always good. And there is certain limitation. There is certain limitation with this. That is we are going to talk. But as such, for almost all the epiphyseal fractures can be addressed by nail injury. So there is certain limitation, so certain contraindication. That is what I want to tell you first. That if the epiphysis is yet to finish, if there is a malunion, supposing the patient has a malunion earlier, there is a fracture there, the medullary cavity is obliterated, some sort of angulation is there. Probably this is not a good candidate to cover and recourse. So you have to select. Osteopetrosis is a condition where the medullary cavity is too narrow. So if you try to negotiate it, probably you will end up with some disaster. Compound fracture type 3BC. BC is a bit controversial. C most of the time do not go for you. Do not go for you. So before going for it, though almost all the fractures of the epiphysis can be addressed, there are certain limitations to be kept in mind. In those situations, probably you should also have a backup with all implants, probably for plate. Now, question arises about the metaphyseal fractures. It is true that people are trying to address this metaphyseal fracture, epiphyseal fracture, plafond fracture, and your tibial fracture, with the help of this modification of the nail of the expert nail. Expert nail is nothing but the same nail where your interlocking goes in different directions to address this problem. But since today we do have good quality of pre-contoured locking plate device to address this, probably it is judicious to use this rather than going for this where there is interarticular involvement. But people are trying. So nail people wish to extend the indication up to the level of this metaphyseal and epiphyseal fractures, plafond fracture. And people are saying that this can be addressed better. So you have to give your own judgment to select the cases. But most of the time, the diaphyseal fractures can be addressed. There is no controversy about that. Most of the time, diaphyseal fractures can be addressed by the nail. So, going to talk about the different techniques. Now, today we are going to talk practical things. Practical thing, what is the entry point? What is the meaning of on-axis and off-axis? You all know, off-axis is the axillary, which is not exactly same with the medullary cavity line. Just like the K-nail. So, K-nail was the inventor of the nailing system, where the limitations of which being crossed over by Gopi Kempe, later on with the help of interlocking device, to address the rotational instability. Though he also tried to do interlocking fixations, pinchers itself. So clover left shape is basically to address this thing. But even then, this is the basic mother of nail. So there is invention later on, the first generation, third generation is coming up to address the problem faced by the previous generations. That is the basic thing. Modification is being done by this. Now, what are the techniques? We are going to talk about some practical aspects. There are two types of entry: suprapatellar, infrapatellar. Now, in today's picture, it is seen that most of the surgeons they prefer to go suprapatellar rather than infrapatellar. The infrapatellar is more conventionally being used earlier days. Nowadays, it is seen that there is tendency to go for suprapatellar. But I personally do not prefer it. Why so? My logic is saying simple that a virgin knee joint should not be internal. I do have the problem with the tibia. So I should be able to find out the solutions to address the problem which is limited to this. Why unnecessarily violating a normal joint? That is why this should do. I do not know, but there is a consensus coming up nowadays to go for this. But even then, the long-term studies yet to come out, particularly suprapatellar, what is the consequence of this to knee joint in later period? Probably violating this joint somehow, your patellofemoral joint is somehow being disturbed, and some sort of your insult is always there inside the joint and articular surface. But in long term, probably he may go for osteoarthritic other changes later on. Since you are doing the rimming and other thing also, you are leaving behind some debris inside. So this may some sort of your insult is there. So, but I believe, I strongly feel that the problem which can be addressed by this infrapatellar entry is judicious rather than violating a virgin joint. But in those situations, yes, certain cases where you need to do suprapatellar, indication are proximal and most of the time distal also. Distal, why this said is distal can be addressed by the infrapatellar also. But if you cannot maintain the reduction, because it is seen that while you are doing the reduction, so maintaining the reduction, there it gets disturbed if you have infrapatellar entry point. So that is why there people are addressing for the suprapatellar entry point. Yes, that is why. But that can be also addressed. Now, first thing is that the name, position and other things are always you know. So it is said that it is better to put a bolster in the same buttock so as to prevent the tendency of externalization. One point, the positioning. Other CM and other things we are not going to talk because these are the conventional things you used to do always. So you make yourself helpful, convenient, so that without any interruptions or any problem we can address this. So the position of the CM, position of the surgeon, other things are there. Now, first thing is that I must have good reduction. This is the prerequisite. So how to maintain the reduction and how to achieve the reduction? What are the techniques? Earlier techniques were there that people used to pass a statement pin through the calcaneum to give a traction. That is one of the logic where you do less assistance. Even you can pass the pin through the just above the knee joint and ankle joint in the epiphyseal scar. Statement pin gives traction. Another techniques are on this manipulation, simple hand manipulation, number 1. Number 2, traction. Number 3, is there any more technique? Yes, we can even apply something distractor. Distractor you can apply one in proximal and distally so that you can put the distraction so you can have a distraction. Number 4 is that in the case of your compound fracture, what is most easy to do?
The plate.
Put a unicortical plate and do it with my and remove the plate. So that can be done easy. One of the easiest way to do maintain the reduction till your job is over. Once it is over, you can remove it. But these are the techniques. Even you can joystick sort of techniques. Joystick. Sometimes you can play. Suppose there is oblique fracture like this, then you can give a compressive from the other side. Other side you can do pulling, pushing. So these techniques can be applied. And finally, in those situations we are unable to do is a mini exposure. So these are the way. One is a conventional technique traction, pin, calcaneum, even if you are above the plafond, traction. Then your ligament, I mean to say distractor, fix it. Open fracture you can apply a unicortical plate. Then even fixators can be applied outside to push it and push it. So this is to maintain the reduction, achieve the reduction. Then finally you have to introduce a nail. So in the nail, let us talk about the nail and the entry point also. So in the suprapatellar entry point, it is above the suprapatellar joint, midline incision, you have to go. This and other things are defined. Now, let us talk about the conventional nail. What is the difference? What is the significance of the nail? What is the angle? And what is the importance of the angle?
Hedgehog angle.
Harsh's angle. What is the degree?
110 to
110 degree.
110.
110 degree is the angle. 110 degree is the angle. So Harsh's angle is the Harsh's modifications of the nail. Earlier this K nail was straight one. So straight one is going through the nail up to inside the joint. So to avoid this problem, we are having this angle. Yes, sir. So it on off axis, basically to off axis. 1 point. Now where to put the injection? Now we do have in the knee joint. We do model of solution knee joint. How to approach? What are the points? What is the entry point here? Classically, it is the medial body of the lateral. So medial slope of the lateral. Medial slope. If lateral is no? Lateral. Medial slope of the lateral tibial spine. Medial slope of the lateral spine. Yes, sir. So there are 3. Suprapatellar 1.
Parapatellar.
But in case of infrapatellar, you have 3. One is through the tendon. One is medial parapatellar. Lateral. Another is your medial. So these are the exposures. Borsat it kone ase niki? Borsat aru Fukan. So one is your incision. Now where to what? Where to what? So if there is a flexure in the upper 1/3, what is best? Is it going for the medial or lateral? Lateral. To prevent this angulation. It is true. It is sometimes it is very difficult to negotiate. 1 point. Okay? So for the distal part, it is almost medial. Our middle part, one can go for the straight. So in the infrapatellar, we do have 3 exposures. Medial parapatellar, through the tendon, lateral. So entry point classically is the medial slope of the lateral spinous process. That is your midline. Now, the important thing is that always you have to keep in mind the entry point should be in the perfect APV. So if there is a rotation a bit, you have a confusion. So if it rotation you find it is in midline, actually not. So how to get the pure APV? The pure APV will get if the lateral border of the tibia is bisecting the fibular head. If you get a gap here, you will know this is internal rotation. If it is more overlapping, so that is why in the entry point, if you want to confirm it with the help of the CR, I is supposed to have a pure APV. And in case of lateral view, is supposed to the contact should be overlap. So these are the pure views. Pure views are important because little bit of your angulations may confuse you. You may find in the textbook also sign that in the AP view you are getting this, but in rotation if you are doing the Siam is also not in the perfect position, there is a rotation, you will find the entry point is stability. So you get a confusion. So I am supposed to have a pure AP view so that my entry point is correct. Once the entry point is not correct, you will have to struggle a lot because it is not going to be negotiating. It is not a negotiating, it will always get problem. So it is just like the guide. If the guide is going wrong way, the subsequent followers will also go the wrong track. So your guide should be correct so that the other things are also correct. So there is so entry point is very important. So if your entry point is not correct, the other things will always point the problem. The problem is mostly thin in case of your proximal tibia flexors. So you cannot do sufficient flexion. So keeping position and the suspension, sometimes you used to have a radiolucent triangular device so that it doesn't interfere. You can have a semi-flex position, semi-extend position, semi-extend position. So this is the position. Sometimes you may need to do hyperflexion so as the entry is also correct. So this time probably sometime you may find difficulty in the proximal fibula. So to negotiate it. Right, sir? Yes, sir. So this is APV. What about the lateral point? When in this plane, lateral plane, where is the point? The point is where?
Tibial plateau and tibial angle.
Pardon?
Junction of tibial plateau and anterior border of tibial plateau.
That is a radiological view. But what about the intraoperative view?
So there is a slope, sir. So
What?
just behind the
No,
Hoffa's
it
pit,
is
sir.
just anterior to the intermeniscal ligament. So you do have a meniscus here. So you can find a transverse bend. Just retropatellar factory is detected, you will find. This is the area where you are supposed to be anterior to it. Yes, sir? So AP view, you know, I am in the medial slope of the lateral spinous process. In the lateral view, I supposed to be, as he said,
Anterior slope,
but
sir.
interior, one can see, because I am opening and I can see, I supposed to be anterior to this ligament. So I do not have, sir. Intermeniscal ligament, anterior to the intermeniscal. This is the zone where you have to enter. Acha, now when you are entering your direction, usually go posterior first. Diamond level is not here, no? Diamond level, no. Acha. Diamond level. So okay, fine. Then your entry point is made. So next point is that we have, this is it. So position of the is there. We are maintaining this position with the help of the device of traction, whatever it might be. Entry point I am finding with the help of your CM. Okay, fine. Otherwise, one can also calculate it out. Laterally is supposed to be internal and anteriorly. And if you open it up, you can see the intermeniscal ligament anterior. This our entry point should be anterior. Once it is going in with the diamond awel, you are making a hole. Then put the guide. Acha, where the guide should be land? We do have two types of guide. One is with the knob, another is plain. So if you are going to use a flexible lemur, so it is always you have to use the round one. Round one. Where is supposed to land?
Some midline.
It's supposed to land on the
Scar.
it's supposed to land in the
Scar.
this is scar. So in the X-ray you have to look at it. So this is very important, particularly in case of the committed fracture. Committed fracture, what you cannot have a very anatomic reduction here. Suppose the fragment is very closely committed. So in the X-ray also you cannot have a very good idea about the reduction. Then what is judgment? In this case, what is judgment? Judgment then I do not have rotation. And I also maintain the length. Two things, mostly. I cannot have a very good reduction. Suppose there is a transverse fracture, you can have a reduction, you know that I am perfect. So it is not important. Because it will be aligned if the reduction is good. But if in case of your committed fracture, you cannot have a good reduction. So in this situation, what best? You are concerned about two things. One, the rotation, another is your shortening, length. These things have to be tested. So that is why your guider should land on the your speed scale, dead center in the anterior, dead center in the lateral. So I will go for a view here, lateral view here, and I see I want to make it. If there is some sort of going anterior posterior, you have to negotiate it and do it around. That is a prerequisite. So in the case also committed fracture, you also clinically have the idea that my point is here in particular, and your second disease should to be aligned clinically. This is more important in case of your committed fracture. So in the committed fracture, you can have a rotation also. How do you judge it? So judgment is coming from the clinical hand. In case of transverse or oblique fracture, you can reduce it. Reduction make you happy that I am aligned. But that problem most of the time you face with the committed fracture. I want to have length. I do not want to have rotation. So that a clinical judgment is equally important. Next point is going for the rimming. So how to study rimming? Do not study rimming without entering inside. This is a very important thing. So once we should go inside, then you do rimming. If you are using the flexible lemur, the first lemur is important, which is called tracking. So it gives a track. End cutting. In end cutting, you are coming length. So you give a track. Subsequent lemur is widening it. Now question arises, how much I supposed to do? In a conventional Indian population, it is say I must go at the most we can go up to 11. Not beyond that most of the time, because our bones are like this. They, in other tribes or in European countries, this is different thing. Sometimes you go for bigger ones, so big bone, big only with different thing. But it is true that if I am doing the more rimming, necessarily I can able to negotiate more bigger nail. Bigger is better, it is true. But at the cost of what? I am cutting the bone also. Now tell me what condition we supposed to not do the rimming.
Chest injury.
1, 2, 3 things I must tell you. That application of the tourniquet. Do not use tourniquet during time of your rimming. So you may jeopardize the nerves. Sudden flash of your necrotic area, you will go inside and perfect clogging. Do not do. I am not going to rimming particularly. Rimming is a controversial thing many times. The studies also pros and cons are there. But it is true even in case of your patient, multiple polytrauma cases, particularly chest injury and other things, better not to do the rimming. And one judgment is also there whether you compound exercise to do or do not do. The pros and cons are there. Logic is here that you do have the blood supply to the bone from the two sources. One is endostatic, one is periostetic. In a compound fracture, what is I am doing periosteal stripping, damaging the outer network. And my rimming is also doing the same thing, jeopardize something. So logic behind is that in the case of your compound fracture, where the stripping is there, soft tissue loss, probably it is better not to do it. Logic is this. Otherwise, it is seen that in normal conventional case, I am doing the rimming, then within 2 to 3 weeks time, that revascularization taking place because there is profuse supply from the periosteum. So it will increase this compensatory hyperactivity of the periosteal network to cover up this. Within 2 to 3 weeks time, it is still seen. That is most applicable in a case of your closed fracture. Also, it is true that do not apply traction in rimming during time of rimming. It is true. If you are doing traction, applying a traction and doing the rimming, this patient wants to go for compartment syndrome. Compartment syndrome. So these are the few important points. Where to do rimming, where not to do rimming, how much I supposed to do rimming is a very important thing. How to start it. As I said, initially you start with a smaller one, 8, 8.5, go 0.5, 0.5, 0.5, 0.5, right? Up to the size of the nail and the rimming should be 1.5, better to be safer side. That means if I am going for 11.5, I am supposed to see nail of 10. Okay? Same thing applicable for ratio is there, 1.5 difference is there. That is the extent. How much I am going to do this important is certainly. This word is important. This is your sound. So how much I am cutting the cortex. So you are giving for the cost of your negotiating a bigger nail, if you are cutting it, you are essentially cutting normal bone also. In long run, that is also going to do some sort of damage because bone should not be replaced by a metal. Bone should be replaced by bone. So if I am cutting, I am doing more damage. But logic is that you are supposed to go to a reasonable extent so that I can negotiate a better and bigger nail. This is logic. So you have a limitation as well. So one point, how to start it. Do not do the rimming starting before entering. You always start go. 1 point, go continuously, do not stop. You can go to and fro. Do not stop. If you stop, it may be, and with the flexible limb, do not try to do reversing. Because reversing will uncoiling it. No traction, no tourniquet. Multiple soft tissue injury, compound fracture, stripping, better not to go. Polytrauma cases, particularly chest injury, better not to go. Be in safer side. There is no harm doing so because almost studies are almost same. They are saying almost results are almost same. So that is why you have a limitation to rimming and very justification rimming. Over rimming of this part is important because to negotiate the proximal part. So any question in the context of rimming? Okay, sir? So we can do rimming, one flexible limb, one fixed limb, one use it, bottom be wide, bottom be light. But these are the logic you have to adhere with while doing the rimming. Next point is that Acha, one point I would like to ask you in this context, how much angulation and rotation is acceptable in tibia?
To 10 degree and 20 degree.
That's right. How much? Negotiable, acceptable. 5 degree, 5 to 10 degree of, no, 5 degree, 0 to 5 degree angulation, 0 to 5 degree medial lateral angulation and opposite angulation. It is said that 1 centimeter shortening can be acceptable. Rotation, it is said up to 20 at the most, not beyond that. So these are the negotiable, acceptable conditions in the case of tibia. But tibia means as such is, so there is no ball and socket joint. So unlike your femur or in case of humerus, that's a different thing. Here you cannot, because both the joints are fixed, so you cannot accommodate. So if you are doing more angulation, it is going to affect the joint as well. Yes, sir. So one can, at the most, one can accept shortening up to 10 mm. 5 degree this side, 5 degree this side, 0 to 10 degree this side. Acceptability of tibia. This is acceptability. Beyond that, it will cause damage. So this is acceptable. Next point is the same. This is not very difficult to negotiate it. Do not try to do the hammering while putting in nail. And what is nail size? Nail size two. One is length, one is size. One is this size. What is size I am going to use? So size of this nail will be determined by what? Rimmer. So rimmer and rimmer size is 1.5. 1.5. Better to be 1.5. Sometimes people used to go for even 2 also. 1.5. 1.5. That is difference. 1. Length you have to measure. 2 ways. One is the indirect technique, one is direct technique. One can put the nail in upper and also the see what is the length I am taking. 1 point. Number 2, you can take the help of this your guide rule also. Evidence to select the length of the nail. Next time if you go for the but better not to do a hammering. So if you are doing, try to do the negotiations with your hand. That is best to negotiate it rather than going for the hammering. Hammering in the final setting one is acceptable. Otherwise no. Otherwise if you are doing so it may do some injury or damage. So after that we are going to for what? Locking screw. What is the size of the screw? What is the size of the screw? You determine?
So 4 nails size 9 mm and above. We use the 4 nails of diameter 9 mm and above.
If it's 9, what is the size?
So 3.9.
If it is more than 3.9.
3.9 for below 9.
And
For above 9,
4.9.
4.9 sir.
3.9 and 4.9. Yes, 3.9 and 4.9 is the size you are going to. So distal is most of the time it is a freehand.
Yes.
Distal is most of the time a freehand, but also jigs are available. Even then, it is most of the surgeons prefer to prefer freehand. So bull's eye. You try to have a round bull's eye. Bull's eye. So as to have a bull's eye in the, so that you can do the. And regarding your length, what is the ideal one? Ideal one. So if I am putting like this screw, it is said if you keep 1 or 2 thread out this side, 1 or 2 thread out this side, it is better stability rather than a flush one. It gives more better stability. 1 or 2 thread this side and 1 or 2 thread this side is giving better strength, better stability. So distal locking is first to do. With the help of your guider also you will know what is the size and take the measurement. Other things are there. So meanwhile, one step is there that the exchange of your guide wire. So if you are using a knob one, then you have to go for plain one. So for this what you are going to do?
Exchange tube sir.
Exchange. So you have to pass the tube here, then you have to exchange it. But this is not applicable in case of your hand rimmer, where you are using a plain blade. So that sometimes people used to forget that what to be done. So that leads to another disaster, difficulty. So you have to remove everything and go for it. So exchange of the guide wire is important in between, so as to prevent any other complications. Length and other things are discussed. So and then screw size is 4.9 and 3.9. So depending on nail, what nail I am going to use. What nail you are going to use. Then other points are simple. Now what is your take home message? What is the advantage of this nailing? Advantage is their load sharing. Unlike a plate and external fixators, these are away from the medullary cavity. Surface, or you can say eccentric device. So eccentric device usually take the load itself. So it inevitably goes for failure. So here in these things are different. Here the nail is bearing the weight. So it load sharing. That is load bearing. So sharing is better rather than the, so if the implant is bearing too much load, the implant going to fail. So if it is, that is why the failure chance is less. And regarding the weight bearing, and what is the advantage? Advantage, you can give the movement immediately. And one can give full weight bearing next time, depending on condition. Not always true. Not always true. So that is the advantage. Number 2 point is coming there. Sometimes you go for dynamization. What is the time to go for dynamization? How to do the dynamization? So if you look at this nail, you will find this slot. This slot is important. So you will find while I am putting this here. So while I am doing then interlocking, you will find the screw is here.
Eccentric.
Here. While I am finding it, because so while you are doing the dynamization, suppose you want to dynamize, I want to have a compression, patient is not having good area, there is still gap after 2-3 months time. So controversy is there, what is the right time to go for dynamization? So sometimes you have to go select. So it depends upon certain conditions. And which part should be dynamized is also another logic. But normally, conventionally, their screws is or slot is always there. So if you find, then you will find that while we are doing the interlocking, you will find your proximal one screw is lying proximal. So while doing the dynamization, what I am going to do? I am removing this or this?
Static one, sir. Static screw, sir.
So if you are removing this, then if you are compression, this nail screw will be coming like this. So there is progression, migration of this here. So necessarily screw is coming down. This excursion will be doing the compression fixation. So that is why they sometimes people forget which screw I supposed to use. I suppose you know this static one to make it dynamization. So that is called dynamization. As such, another principle dynamization is said depending upon the fragment size. So it is longer deep fragment.
Longer long segment dynamization.
Yes, that is another concept of dynamization. Two concepts, one is this, another is this. This is inborn device. There is also you can modify it. Yes, sir. So these are the points that you do the dynamization. You do the heavy. The principle behind this, how to do fixation. What are the complications you may face? Particularly all the complications start with the entry. Then if your entry is not good, you will face the problem. So that is why you may take the help of the CM and the entry point is correct. If my entry point is not correct, if it is going too much posteriorly, or if it is not correct reduction here, then probably you will get the problem. So always try to have a good reduction. Maintain the reduction till you can put the nail inside. So this is your concept. So this gives a very good result rather than that of other plates and other devices. So people are opting for it. Even though other concepts are always there. Because one can go for conjunctive treatment in certain cases. The difference between this and that, you can early mobilize. You can bring the patient back to the profession early with the help of this device. This is the advantage of this situation. Unlike your plaster, where you have to be there for a long time and there is some complications, stiffness may be there. But here you can give early mobilization with the knee joint and the elbow joint. So that always gives a better outcome of a fracture tibia.